Unfortunately, there are limits to the amounts of information we have access to when designing these plans. For example, we currently have very little understanding of the changes in neurological control of various muscles that may occur following a significant operation like a shoulder replacement. This is important information. If we can identify patients who are likely to have poor outcomes preoperatively, we can administer targeted therapies to improve these outcomes. As a surgeon, I want to make sure that I'm giving my patients the best possible care. But that can be difficult when clinical practice lags behind current research. It's commonly stated that the time for research to reach clinical practice is between 8 and 17 years, depending on what kind of intervention you're examining. To address this, we need to develop models, including artificial tissues, implant testing schemes, to enable us to speed up the translational pipeline between research and clinical practice. These challenges were front of mind when the Queensland Unit for Advanced Shoulder Research was formed in 2017. We were fortunate to be able to leverage resources available at QUT and extended Quasar into an ARC ITTC training centre with the launch in 2020, which was 4 years ago. Together with 5 medtech partners, Zimmer Biomet, Stryker, Materialise, Australian Biotechnologies, and Logimas, along with 3 universities, Queensland University of Technology, University of Queensland, and University of New South Wales, we raised $7.7 million in funding. Our mission was to transform and translate biomechanical education using multi-sector collaboration and industry partnerships to empower the future workforce and improve patient outcomes. Our research focuses on 3 pillars. 1, advancing fundamental knowledge and technology. 2, workforce development to improve clinical and industry-informed researchers. 3, commercialization, to translate our research into industry-relevant outcomes. To address these challenges, our research at the ITTC was undertaken under 4 programs. 1, biomechanics and medical AI. 2, medical robotics and joint implant testing. 3, bioengineered tissue scaffolds. 4, rehabilitation science and neurophysiology. Program 1, biomechanics and medical AI. In this program, we're developing multi-scale in silico and in vitro joint simulators to investigate limb biomechanics. The interesting thing here is everyone thinks of the shoulder as, it's commonly we get focused with the shoulder on the glenohumeral joint. And we forget that the shoulder is actually the glenohumeral joint and the scapulothoracic articulation. And these models are very interesting because they're really pushing into that relationship between the glenohumeral joint and the scapulothoracic articulation. And I think that's going to be very important in our shoulder surgery in terms of understanding the shoulder much better than we currently do. Program 2, medical robotics and joint implant testing. Our work in medical robotics and joint implant testing focuses on developing technologies for planning and executing joint surgery. One of the robotics has come in with the hips and knees. There are good robotic machines that will help perform a hip or a knee replacement. But we just don't have that in the shoulder yet. And the shoulder is more complex in terms of developing a robot that can do joint surgery or arthroscopic surgery. And it's pretty exciting to be part of that development. It's slow going, but the group are making some inroads there. Program 3 was bioengineered tissue scaffolds. So I think this is one of the most interesting ones. This is really exciting for me as a shoulder surgeon, where I think we can see something fairly soon. The example that I give you is rotator cuff surgery. Rotator cuff repairs re-tear, and they re-tear frequently. In the overseas studies, these are large multi-center trials. The re-tear rate for rotator cuff repair is 40%. Now, I don't know about you, but I wouldn't be too keen fronting up for an operation where there's flip a coin as to whether it's going to work or not. And the idea is that we could provide a scaffold or a reinforcing layer that would then stimulate the repair of that tendon such that it was much less likely to re-tear. And so I think that's extremely interesting. The fourth one, rehabilitation science and neurophysiology. This is looking at wearable devices and so on that will guide us with our rehab. Post-operative rehab is a funny thing. You know, I've got a concept when I ask my patients after a rotator cuff repair to wear a sling for 6 weeks, and then we bring them back and I scan them at 6 weeks with an MRI scan, look at their rotator cuff, and then I bring them back at 12 weeks' time and scan them again, look at their rotator cuff. Rotator cuff repairs, if you don't know, they re-tear between 6 and 12 weeks post-op. That's the period of time. They rarely re-tear before 6 weeks. They typically re-tear between 6 and 12 weeks. It's very rare to see them tear after 3 months. Why do they re-tear in that 6 weeks? Well, they've been in a sling for 6 weeks, so they don't tear during that time. They come out of the sling, they start moving, and the tendon has not healed enough to the footprint of the shoulder, and it just pulls off. Sure, they can have a fall, but typically what we see is patients doing too much movement and it pulls off. Well, how much is too much movement? We have no current way of quantifying that. Imagine a wearable device such as a watch that could accurately quantify how much movement that patient was doing during that 6 to 8 week period. I am scanning them. Many of my colleagues are now scanning patients post-operatively and watching the rotator cuffs. And we could accurately tell you, well, if you do this much movement, you're going to be in that band of risk for a re-tear. If you stay out of that band of movement, you're very unlikely to have a re-tear. We wouldn't, you know, right now, what do I do if they're a really big tear? I keep them in a sling for the further 6 weeks. Can you imagine being in a sling for 3 months of your life? I can't imagine 2 weeks, let alone 3 months. But that's currently what we're doing. So I think that is a really interesting area of research. And it may not leap out at you like that when you first hear it. Since 2020, our team has published 160 papers and delivered 242 scientific presentations. And I think that's pretty impressive work from the researchers here. It really is extraordinary. I've contributed a little bit to it, but the majority of that has been done by hardworking researchers here at QUT. This body work has contributed to our knowledge and practice in orthopedics of the shoulder. Our increased clinical engagement conferences with over 60 presentations in 2024 alone has fostered a vibrant exchange of ideas and best practices. Notably, we received the 2024 ICSIS Basic Science Award for Biomechanical Analysis of Shoulder Fixation Constructs, and that's a testament to the high quality and impact of the research being conducted. I also want to mention that at a research and training centre, we have created a unique environment for our 18 PhD students and affiliated researchers to directly learn from clinical and medtech industry experts so that they can understand the real challenges, not only in the clinical world, but how to do translational research to boost Australia's medtech industry capacity. We see significant advances in fundamental knowledge that our trainees and graduates are taking with them to continue the legacy of innovation in orthopedics. The pipeline of funding and awards is a testament to the quality of our collaborative work thus far, and you can see some of that on the slide there. Our researchers have been active in receiving grants and moving forward with their research which is commendable. And their overall vision is of raising the bar for clinical, medtech, and academic interdisciplinary collaboration to revolutionise patient care. And I believe that's being achieved. So we'd now like to turn the session towards what we really actually focus on, the end result of everything we do, which is our patients and patient experience. We're very fortunate to have Dr. John Taskey and Professor Paul Burnett with us today. Dr. Taskey underwent a reverse shoulder replacement 2 years ago, and he's here to share his experience with us from that very significant operation that he had. And Emeritus Professor Paul Burnett had 2 arthroscopic rotator cuff repair surgeries in the last year, and he's very kindly agreed to come along and share us his experiences as well. Both are very senior, very accomplished men. Dr. John Taskey is a retired, highly regarded senior anaesthetist, both at the Princess Alexandra Hospital and in private practice in Brisbane. In a past life, John was a member of the Australian SAS service. He's also led a very active and fulfilling life outside of his professional life, including having climbed Mount Everest, which was a significant achievement. Professor Paul Burnett is a highly respected QUT Emeritus Professor. He retired in 2016 as Dean of Research and Research Training. Prior to that, he was Deputy Vice-Chancellor of Research at Charles Sturt University. Paul has over 100 publications and has been associated with more than $1 million in research grants. I'd like to discuss their journeys with you so that you can see the end result of our research and that human side to what we do. So I'd like to invite Paul and John up here. Could we just get them microphones? Take a seat here. So Paul and John have very kindly agreed that I can share their clinical story with you. So Paul's 68-year-old, is 68, he's right-hand dominant, and he's had bilateral shoulder pain for about a year before he came to see me. He'd retired and he decided he was going to play golf. How many swings were you doing a week?
Oh, lots. Too many, clearly, with consequences.
And what did you experience, Paul? What were the symptoms you were getting with your shoulders?
Is this working? Oh, great. I was getting severe pain, particularly in the left shoulder. The right shoulder wasn't as bad. And it got to the stage where I couldn't swing a golf club over a period of time. And then I had trouble sleeping, particularly the pain in the evening. I don't know whether that's caused by different tensions on the shoulder during sleep and lying down, but it was incredibly painful. So that's when I decided to search around to do something about it.
So you couldn't sleep, couldn't play golf, you retired, but you couldn't do much else, could you?
No, because I was playing golf 2 and 3 times a week, and I was very passionate about it. But I was practicing daily to improve my swing. So it really impacted on what I was passionate about after leaving an academic career and having great commitment and passion towards that. I was searching for something else in retirement. It was a bit of a blow, really.
One of the things that has come to stick in my head about doing shoulder surgery is that the dichotomy. I started off doing neurosurgery. I did a couple of years on the neurosurgery training program. And for me, it's the dichotomy between the brain surgery and the shoulder surgery. Everyone thinks about brain surgery and how, you've got something wrong with the brain. I tell you, I don't think anyone thinks about their shoulder until it's bad. But then I tell them, but you think about it all the time, don't you? Because you can't sleep, you can't work, and you can't play sport. And it takes you may not die from it, but it takes your life away from you. And to all of you out there, one of the wonderful things about shoulder surgery is you can usually give them their life back. And that's pretty cool. So you had a cortisone injection and it helped for a bit, didn't it?
Yeah, not very much. I had 2 cortisones in the left and 1 in the right.
So, is that a pointer? So we've got a rotator cuff, a full thickness rotator cuff tear here. That's the tendon This is the rotator cuff tendon. The white there is fluid. That's a gap. It comes across the top of the cartilage and it should join onto the footprint there. That gap is about 1 centimetre, so it's retracted back. So it's a complete full thickness tear of the supraspinatus tendon with a little bit of retraction.